Hey future nurses, welcome back to NCLEX-bay. Today we are conquering the ultimate masterclass blueprint on integumentary medications.
But before we dive into the core facts, let's test your baseline clinical judgment with this critical board-style question. A topical corticosteroid is prescribed for a hospitalized client to treat an inflammatory skin condition on the neck. To which other body areas could the nurse safely apply this medication if prescribed? Options: 1. Back, 2. Axilla, 3. Eyelids, 4. Soles of the feet, 5. Palms of the hands. Lock your thoughts in. We are going to break down the exact clinical science right now. And I will reveal the correct answer and rationale as our first question in the quiz at the end of this explainer. Let's get it.
Okay, let's hit the ground running with poison ivy, oak, and sumac. You're on the floor, your client is itching like crazy. What do? Your immediate non-pharmacological go-tos are calamine lotion and soothing colloidal oatmeal baths. Aluminum acetate compresses are also fantastic because they act as a potent astringent and antiseptic. But listen closely to the pharmacology here. If you're pulling topical corticosteroids to stop that inflammation, you absolutely must apply them before the blisters actually form. If the blisters are already there, it's too late for topicals. That's when you have to pivot to heavy hitters like oral corticosteroids and systemic antihistamines like diphenhydramine.
Now, speaking of those topical glucocorticoids, you've got to know your permeability zones like the back of your hand. Look, human skin isn't just one uniform wrapper. While intact adult skin is generally a solid barrier, highly permeable areas, think the scalp, axilla, face, neck, eyelids, and perineum, act like an absolute sponge. They carry a massive risk for unintended systemic absorption. Compare that to low-risk, poor permeability zones like the palms, soles of the feet, and the back. And a golden rule? Never, ever apply these meds to broken or denuded skin unless the provider explicitly writes it, because that sends systemic absorption straight through the roof.
Hold up. Let's pause right here because this is a non-negotiable safety guardrail for your boards and your literal career. You and any family caregivers you're educating must always wear gloves when administering any topical medication or patch, period. If you don't glove up, guess what? You're giving yourself a dose of the patient's medication straight into your own bloodstream. Wash your hands, glove up, apply, take them off, wash again. Protect yourself.
So what's the big deal if a patient gets systemic absorption? Well, if you ignore those permeability zones or use these topicals over massive areas for way too long, you are inviting severe systemic adverse effects. We are talking adrenal suppression, we're talking Cushing syndrome. In our pediatric clients, it can literally cause growth retardation. Plus, you've got local and ocular issues, skin atrophy, striae, and even glaucoma and cataracts. To dodge this, apply a super thin film, rub it in gently, and absolutely no dry occlusive dressings unless explicitly ordered. Occlusion traps the med and skyrockets absorption.
All right, shifting gears to chronic conditions like atopic dermatitis or eczema. When basic moisturizers and topical steroids just aren't cutting it, we escalate to topical immunosuppressants. Think tacrolimus and pimecrolimus creams. But these are not benign lotions, okay? They come with glaring red flag warnings. They cause severe sun sensitization, so your client must aggressively protect their skin from UV rays. And even higher yield for your exams, tacrolimus increases the risk of skin cancer and lymphoma. Plus, in kids, it actually spikes their risk of a varicella zoster infection.
Next up is actinic keratosis. These are those rough, scaly lesions you get from years of baking in the sun, and they can totally progress to squamous cell carcinoma. You must memorize the exact healing timelines for these topicals, because client compliance is everything here. Fluorouracil messes with DNA and RNA synthesis and gets to work in about 2 to 6 weeks. Diclofenac sodium, that's an NSA gel, and it can take up to 3 months. And then there's imiquimod 5% cream, which, fun fact, also treats venereal warts, but it takes a full 4 months to do its job.
Now, if the words aminovivulinic acid pop up on your screen, I want your brain to instantly shout photodynamic therapy. The protocol here is extremely specific. You apply the medication directly to the lesions, and then you wait. It does absolutely nothing until it's activated exactly 14 to 18 hours later by a specialized blue light. And during that waiting period, the client has to protect those spots from the sun and even bright indoor lights, or they're going to experience some really severe burning and swelling.
So how do we prevent all this sun damage? Sunscreens. These are guaranteed easy points on your exam if you just know the core mechanics. It's pretty simple. Organic or chemical sunscreens work by literally absorbing the UV light. Inorganic sunscreens, the physical ones, act as an actual shield on the skin, physically reflecting and scattering the UV light away.
But sunscreen is totally useless if your client doesn't apply it correctly, right? The rules are strict. Instruct them to grab a broad-spectrum product, meaning it blocks both UVA and UVB rays, with an SPF of 15 or higher. They gotta slather it on at least 30 minutes before they even step foot outside, and they must religiously reapply every 2 to 3 hours, or immediately after they've been sweating or swimming. Oh, and remind them that UV rays are absolutely brutal between 10 a.m. and 4 p.m., so extra caution is needed then. But wait, high-yield exception pattern interrupt. Pay close attention to this one. If that sunscreen contains PABA, para-aminobenzoic acid, that standard 30-minute rule is out. It actually needs a full 2 hours to soak in before sun exposure. And here's the real kicker. PABA products are entirely contraindicated if your client has allergies to benzocaine, sulfonamide antibiotics, or thiazide diuretics due to a nasty cross-sensitivity. Do not miss that on the exam.
Let's keep this momentum going and jump into psoriasis. For mild cases, we use topical glucocorticoids. But remember to keep them far away from the face, groin, and axilla to avoid skin atrophy. Tazarotene? That's a vitamin A derivative. Have your client apply it just once daily in the evening to dry skin, and warn them about sun sensitivity. Then there's calcipotriene, a vitamin D analog that, in really high doses, can actually throw them into hypercalcemia. And finally, coal tar. It suppresses DNA synthesis, but give your client a heads up. It smells awful, and it will absolutely stain their skin and hair.
Now, for psoriasis, we also use keratolytics like salicylic acid to melt away those thick scales. But there's a huge danger zone here. If you apply this to massive surface areas or over open wounds, it gets absorbed systemically and triggers a toxic crisis called salicylism. What does that look like? Watch for dizziness, a ringing in the ears called tinnitus, hyperpnea, and even psychological disturbances. If your client mentions their ears are ringing, you stop that medication immediately.
When those topicals fail, we bring in the heavy artillery, systemic biologicals. And the warnings here are massive. Methotrexate is great at slowing down cell proliferation, but it is super toxic to the liver and GI tract and suppresses bone marrow. But the most critical board fact? It is highly teratogenic. Female clients of childbearing age absolutely must wait 3 full months after stopping this drug before even thinking about getting pregnant.
If you thought methotrexate was intense, look at acitretin for severe psoriasis. This drug is exceptionally embryotoxic and teratogenic. The rules are wildly strict but totally necessary. You have to rule out pregnancy first. Then, the client needs 2 reliable forms of contraception starting a month before treatment, and they have to keep using both forms for a staggering 3 years after they stop the med. No alcohol, no vitamin A supplements, and no tetracyclines. It's a huge commitment. Real quick on acne. Mild cases, gentle cleansing, and maybe a topical antimicrobial. Moderate, we step up to oral antibiotics. But when you see severe, deep, inflammatory cystic acne, like you see right here, we have to rely on aggressive systemic comediolytics like oral isotretinoin to knock it out.
All right, future nurses, it is time to close the loop on that baseline clinical judgment question I threw at you at the very beginning of this explainer. I asked you where else a nurse could safely apply a prescribed topical corticosteroid. You locked in your answers? Now, based on the absolute masterclass we just did, let's see how you scored. The correct answers are options 1, 4, and 5, the back, the soles of the feet, and the palms of the hands. Why? Because these are areas of very poor skin permeability. Applying topical steroids to intact skin in these zones safely prevents that massive, dangerous, systemic absorption into the bloodstream we talked about. You definitely want to steer clear of the highly permeable axilla and eyelids to avoid those terrible systemic effects like adrenal suppression or glaucoma.
You just crushed this high-yield blueprint. But remember, knowing your permeability zones on paper is only half the battle. The real test is when you hit the clinical floor. If your patient is on long-term systemic steroids and suddenly spikes a fever, do you know exactly which life-threatening crisis is unfolding? Think about that, stick to your safety guardrails, keep grinding, and I'll catch you in the next explainer.